So it's with great pleasure that I introduce Pam Rutledge, who is the CEO of Richmond PRA and a very, very strong advocate for person-led services and the employment of people with lived experience. Prior to being with Richmond PRA, Pam had over 35 years' experience in senior roles in New South Wales government, including experience in health, housing, aged care and disability. All the services that we want to get into. It sounds good. So thanks, Pam. And I'd also like to introduce Fay Jackson, who's the General Manager of Inclusion at Richmond PRA. As you know, Fay is also the Deputy Commissioner of the New South Wales Mental Health Commission. She's also, you haven't seen her as a stand-up comedian, but she's one of those as well. Fay's first permanent job at age 40 was as a peer worker for the Illawarra Area Health Service. She then went on to be the Director of Consumer Care and Community Affairs with that service. She has been awarded the Meritorious Service to Community Medal in a Paul Harris Fellow Associate Fellow of UTS and is one of the 11 national mental health leaders, National Commission's mental health leaders. So please welcome Pam and Fay. Thank you.
Thank you, everyone. It's a great pleasure to be here today and to be in conversation, really, with Fay, because what we have in our organisation is a great opportunity to work in collaboration at this level. Fay is in this role of General Manager Inclusion, which was created previously by Janet Ma in the PRA days before our merger. And when I became the CEO of Richmond PRA, I had the great opportunity to learn from Janet and then more recently from Fay in this role. And in terms of creating an environment where we can do something serious about employing people with a lived experience in our organisation, the foundation that this has provided in terms of working at the top to really learn and be accountable for what we're trying to do. We've been really privileged to have that opportunity from both Janet and Fay. And what we're hopefully going to demonstrate here today is the way that we work in collaboration and really by holding each other accountable for the work that we do. So I'm greatly privileged to start this off. Of course, as we've heard already, I don't think we need to labour the evidence that many people have produced already about the value of lived experience practitioners at all levels and of peer workers in particular. And we absolutely have demonstrated that ourselves in the work that we're doing, and it's our commitment to valuing lived experience at all levels of the organisation that drives the sort of changes we're trying to make. And that comes from our board as well as coming from me and working right through the organisation. So that's just the other piece of evidence. I don't need to labour the point. That's the evidence from the peer link studies about the value of linking people to a peer worker, and we see it every day that people feed back how important and valuable it is for them to engage right from the beginning, and how much easier it is to engage with a person who has that lived experience and brings that role modelling of the fact that people can and do recover. So for us, we've come to our current position through two very important pieces of work. The first was our Embracing Inclusion policy paper, which was endorsed by our board in early 2013, following our merger in mid-2012. And this piece of work was done by people with a lived experience, by Janet Ma, Peter Farrugia, who is the manager of our peer workforce program, and by Valley Beattie, who was formerly our workforce development manager. And they put together this paper for our board and for our organisation about employment of people with a lived experience. And so it has these two sub-elements. It's on our website, and you're very welcome to read it if you haven't already. It very clearly articulates the way that we work around encouraging people into our organisation through affirmative action recruitment into any role in the organisation. And that's us walking the talk about being an employer of good value, an employer of choice for people with a lived experience who want to do anything, and that can be accounting or IT or frontline work. The policy clearly articulates the sort of support we provide to encourage people with a lived experience to work in our organisation. The second half of that paper is around peer work as a particular part of our workforce and our commitment to grow our peer workforce and to ensure that we provide a supportive environment for people with a lived experience who are going the extra mile, if you like, or extra kilometre, to actually draw specifically on their lived experience in their role. And that's the distinction we make, as other people have made today, around the definition of peer work. People can work in any role in the organisation as a person with lived experience. They may or may not disclose. Our target at the moment is to have 50% of our workforce as being people with a lived experience by 2017. We're already over 43%. But peer workers are the people who do the extra work of really articulating and drawing on their lived experience in the way that they work with other people who have a lived experience or a mental health issue. And then building on that work, last year we, after many, many months of work to articulate our understanding of recovery for the whole organisation, we went through a very detailed and comprehensive consultation process, bringing staff from all levels together to develop our recovery action framework. And again, Janet was involved in that work before she retired, and Fay was recruited into the position. I think I must have done something very wonderful in a previous life to have such luck to recruit such hugely, fantastically qualified and experienced and skilled people. Mark Orr and Aidan Conway and Phil Naden, before he retired, were involved in that work. And Recovery Action Framework was also endorsed by the board, and it's now being rolled out to all our organisation. So every staff member in the organisation has attended a Recovery Action Framework roadshow where they've engaged in a conversation with Fay and I around recovery and around peer work. And part of the RAF is, as we call it, is that we ensure that people accessing our services, wherever they are able to access a peer worker, and that all peer workers are trained in the requirements of their role, and that includes a Cert 4 in peer work, and that we undertake peer support development and training opportunities to ensure that they can maintain their peer integrity and enhance their skill base. So I might hand over to Fay. Is that the right point? So.
So it's a bit like the news, you know, in the back of the politician, somebody stands up there going, was feeling like that then, yeah, just behind them. Nod now. So it's an amazing honour for me to be working at Richmond PRA, and I was just so agog when I got in there, really, and I said something that I'd been losing the fight on, and I said that I don't really like the term person-centred services, because I've seen through so many services the person sitting in the middle and everybody sitting around them saying, you will do this, you will do that, you will do that. I'd rather have person-led. And they went, oh, okay. And I was like, oh, I was really shocked by that. But working as a peer worker, and I do still see people at the front line, if you like to call it that. But it is that reciprocity, people that I have just met who have just experienced their first episode of having a mental health issue, or their first really traumatic event that's left them feeling really disarmed. I share with them and they share with me, and I learn something from them, and it is reciprocal, and I'm so lucky to be in a position to be able to give to the other peer workers in our service, the other people with lived experience in our service, what I have to give and they give to me. So we talk about, we show, we hope that there is hope for recovery. We mentor people, and that is for people who are connected and people who aren't connected to a service. Richmond PRA, there is no wrong door. They can come in and refer themselves. We are change agents, change for individuals, for their lives. And that person, then they go on and they're a change agent, and it dominoes out. It's a very beautiful thing to see. Peer workers advocate systemically and publicly. They are advocates, they speak in the media now. I was the first consumer speaker, it was called back then, consumer speaker with Beyond Blue. And I was their speaker for a couple of years, because no one else spoke publicly about their lived experience. There were people out there doing, trying to change the advocacy, trying to change the services in behind closed doors, but going up in front of the television and things like that was difficult and new. And then people started coming out of the woodwork, which was really fantastic. We mentor, we tell our knowledge of systems and services and about recovery, things that can help us to recover, like mindfulness and cognitive behavioural therapy, those kinds of things that we actually, as peers, can teach each other. There are psychologists doing that kind of thing, but we also do it. We also teach each other because we've learnt those things, and we share what's worked for us. So we have a knowledge about the systems that other people may not have, and we show that hope. People do say to me regularly, well, if you can do it, maybe I can. I had believed the doctors, the psychiatrists, when they told me that you would never work and you will never be a valuable member of society. I did believe that because they were the doctors, and who was I? I was insane. So what would I know? And then I met a peer worker, and she told me that I could. And she rang me and asked me if I wanted to work with Eugene at the Illawarra Area Health Service, it was called then. And I thought, if she can do it, then maybe I can do it. And that was the beginning of the career. And try that working out where you are in the system, especially in public mental health services, being in the service but not being colonised by the clinical model is very difficult, but something we need to hang on to. So I've talked a little bit about the colonisation. If you don't know what that means, so an example would be, I'm a peer worker, but a psychiatrist asked me to talk a person with lived experience, a person with mental illness, consumer, whatever you want to call us, a person with lived experience, talk them into taking their medication. Well, I'm not a clinician. As a peer worker, I should not do that. I'm not a clinician, and these medications have side effects, and I should not be encouraging people to take medications when the side effects are so strong. And I don't have clinical training. I'm not a doctor. I can't explain all of those things. Yet we are often asked by nurses, doctors, or managers to talk people into engaging with that clinical model, rather than us being within the service but working collaboratively, if need be, with clinicians. So we can be overworked and undervalued quite often, and it is difficult for us to walk away at 5 o'clock when somebody that we see as our brother or our sister are going through a really difficult time. And most of us don't walk away at 5 o'clock. We hang in there. But that generosity can be abused, and also our desire to want to please and to show that we have value and worth can put us in a position where we say yes to everything that we're asked to do. So we can be overworked and undervalued. So there can be, something that I've seen happen, rarely, but I've seen it happen, is negative reciprocity. And that's something that we need to be really careful of. And the services that we work within, both public, NGOs and private, they need to make it a safe place and support us so that we don't become victims within that service. And then when we're trying to support people with lived experience, my victimhood might engage with their victimhood. And instead of growing hope and recovery, we could become enmeshed, and I may not be supporting the person to become agent in their own recovery. So it is really important that there's a safe place for us to recover and to not be enmeshed in the negative things that services have brought us.
I want to say how we manage those risks in our organisation. Yes,
well, we manage those risks by a lot of things, really, a suite of things. We have peer workers at all levels, making sure that how services are being designed are designed with a strong influence of lived experience. We make sure. Did you want to talk to this? We make sure that that people have support. That there is, if somebody is feeling that they aren't being supported as a peer worker, that they have someone else. They do have a manager or someone else they can go to, including going to me if they need to. We have reflective practice where we talk with a supervisor or a manager about how I went today as a peer worker, this is what happened, and reflect on how it went, how it could be better. We use strengths-based language, and that's vitally important so that victimhood and negative language doesn't grow. So we don't talk about, I mentioned before a person that said they were a schizophrenic. How could they? We don't use those labels like a schizophrenic. It's what a person needs in their recovery. That's what we focus on, not their diagnosis, but on what they need. Is it?
Yep.
Yeah. So we use strengths-based language, and if people say I can't do this, I can't do that, talk about what you can do, but what can you do? And there's a big thing that people want to go back to what they were before. But we can't, no one ever can. You can't go back to yesterday. Those of you who've never had a mental health issue in your lives, you can't go back to a week ago. So we need to look forward in a positive way to live our lives forward. Yeah.
So one of the things, 2 minutes. One of the important elements of support for all our staff, but particularly for people with a lived experience and for peer workers, is that we encourage, and this was part of our Embracing Inclusion policy, we encourage people to do a personal situation plan. And so anyone can do that, and we encourage any staff member who has issues in their life that might get in the way of their work, or that might need to be managed at work and supported at work, to do a personal situation plan. And that really brings right into the open discussion the question of how can we support you if you become unwell. And so we do that.
Yes, I've done that. I have that with Pam.
Yeah.
I actually have that with 3 of the senior leadership team in case Pam isn't there, and it's really useful to me. It helped. Recently I wasn't well again, hearing voices, but and very stressed, but I was able to stay in the workplace and work. I did do work. That was good work during that time because I felt safe with them. I didn't have to hide anything, and that's really important. So we don't, it's actually, there's research that says if we take time off work, our recovery is slower. So if we can stay connected and stay feeling useful, our recovery will be faster. We've actually got 5 more minutes because of one person hasn't come, so yes. So,
it's good when you've got the MC.
yes,
It's part of it. So, we've done some more work on the next steps for us in terms of growing our peer workforce, and we're really, as that our opening line was, we're really taking the viewpoint of why not a peer worker. So as every position, particularly frontline position, is advertised, it comes up for recruitment, we ask the question, and the managers are asking the question, why couldn't this position be a peer worker? So that we've got strong position descriptions now, we've got elements in place around the support we provide for peer workers, and we're asking the question, let's actively grow the workforce at the front end, and let's make sure that peer workers absolutely understand that they are there and need to be as accountable as the next person for the work they do. So it is about absolutely recognising the value of lived experience in this workforce, and having really clear policies and frameworks and position descriptions, as other people have said, and recruitment processes. And we are now embarking on a process of reviewing the staff establishment right down at the local level, and bringing in more peer workers. And in a sense, we see peer workers as a mental health worker, and this is an interesting debate with some of the people from the public sector here. They're a mental health worker with this huge added skill set about being able to articulate and draw on their lived experience, and that is valued as such an important skill set.
So what Pam is saying there is that they're not, our peer workers don't do anything clinical. There's nothing clinical there. But when we held a meeting that was really interesting with the, what's the positions of Aidan?
The general managers, operations.
The operations managers, the 2 operations managers, some other managers, cluster managers and managers. And I wanted to have this meeting because I wanted to ask, why aren't peer workers, why can't they be? And why can't they be, each time we have a position available, why isn't it a peer worker that's being recruited? And in that meeting, they'd say, well, they do this. And I'd say, why can't a peer worker do that? Well, they can. Well, they support people to go to the doctors. Why can't a peer worker do that? Oh, well, they can. Well, they support people to connect with their families again. Why can't a peer worker do that? Oh, well, they can. So it was actually really interesting meeting. It was really interesting, and you could see things changed within that meeting. And I would really urge you to ask yourselves about reviewing what positions you do have available, what you want from those positions, and really ask, this stuff, the human stuff, the connectedness stuff, why not peer workers? We can do it. And we can absolutely support people in a way that makes them feel less fearful, less frightened, and we can, with the person's permission, speak with clinicians to support them until when we help them to feel that they can speak up for themselves in what they want to say with clinicians. Why not a peer worker? We're not trying to take nurses' jobs or doctors' jobs or anything like that. What we're trying to do is work collaboratively and make the services better for people.
And as part of that, we're also getting a number of the staff who have been recruited as mental health workers who have a lived experience but didn't apply for a peer worker job, now saying, oh, can I transition over and become a peer worker? I'd like to use my lived experience more purposefully in my work. And so we're working through a process. It's not just, oh yeah, sure, we'll convert you tomorrow.
They have to be the right
We need
people.
to make sure they are the right people, that they have the right skills in terms of being able to use that experience purposefully. But we are setting up a process for doing that and to enable some of our other staff to move into peer work roles. I just wanted to quickly, I know we're running out of time, but very quickly take a little experience of how this sort of approach of thinking fundamentally about what people with a lived experience, the wisdom they bring and the challenges that they can make to the rest of the organisation. Just to draw on the example that we often have debated around medication. And we've, Fay used an example about, our peer workers are not, she would say right at the beginning, our peer workers must not be put in a position where they are advising people about medication. And when we made that comment and they made that point, then at our senior leadership team, we said, well, actually none of our non-clinical staff should be put in a position where they are expected to advise on or indeed to manage someone's medication. And that really brought up a real challenge for us because with absolute respect to my public sector mental health colleagues, we do sometimes find ourselves put into the position as a non-clinical service where we are providing a 24/7 support to a person with a mental health issue, or even in an outreach program, or they're in the getting support from Richmond PRA and they will manage their medication. So that whole discussion really made us rethink, what does that mean in our context? How do we, in a recovery way, support people who are on medication and where there is a clinician who has prescribed that medication, but perhaps the person themselves has not fully understood what the medication does, or what do they do if they're worried about the side effects of medication, or if they want to come off medication or reduce their use of medication. How do we support them in a recovery-focused way, which isn't about us managing their medication? And it was that discussion that has led us to really rethink our whole policy and practice around recovery-oriented support around medication. And it's been a really interesting learning for our organisation, and I think it's fundamentally shifted some of our practices to be more recovery-focused and more person-led. And I'm really proud of that. That's the sort of policy debate and system change that internally we can make because of people like Fay and Janet before her, who are asking those sort of questions and bringing that wisdom of how do we really work in a peer way with people with mental health issues. So that's just one example of the sort of system reform that we're doing internally, and we need to wrap up. Thank you very much. You can talk forever.